Welcome everyone to the West Oncology APP Conference 2021. I will be talking about the new updates in lung cancer. I'm Shayma Kazmi. I'm a thoracic medical oncologist. I work for the University of Pennsylvania Hematology Oncology in New Jersey. So there's a lot on the agenda. I'm going to try to do justice to all of the exciting new data coming through. I can't go through all of it. We'll talk about the CODEBREAK trial with Sotorasib, EXCLAIM, Chrysalis with the new updates in exon 20 insertions, Atezolizumab in the adjuvant setting with IMPOWER 010, the 5-year update with Pacific, and then ADURA, and we'll end with the Destiny Lung 01 trial. So without further ado, let's get right into it. The CODEBREAK 100, was the KRAS G12C mutated non-small cell lung cancer cohort. We know that KRAS tumor driving mutations are approximately present in 30% of patients with lung adenocarcinoma, and these represent about 13%. The G12C represents 13% or half of the KRAS mutations. We know that this mutation has been considered untargetable until recently. In the past 20 years, the trials have investigated the use of various classes of drugs, farnesyl transferase inhibitors, chemo combinations, MEK inhibitors, and they really all failed compared to standard of care chemotherapy. But at World Lung 2020, Lee and colleagues presented the follow-up results from this registrational phase 2 CODEBREAK 100 study evaluating Sotorasib, which was previously called AMG 510, in 124 patients with locally advanced or metastatic non-small cell lung cancer with the KRAS G12C mutation confirmed by central testing, who had previously received platinum-based chemotherapy. So patients had progressed on prior standard therapy, did not have any central nervous system metastases. In this study, patients received Sotorasib 960 milligrams once daily orally until disease progression. The primary endpoint was objective response rate by blinded independent central review, and the key secondary endpoints were duration of response, disease control rate and time to respond, overall survival, and PFS, and safety. So the median age of patients enrolled on the study was approximately 64 years of age, and it ranged from 37 to 80. More than 90% of patients were current or former smokers, and previous systemic therapies included platinum-based chemo in 89.7% of patients, PD-L1 inhibitors in 91% patients, and platinum-based chemotherapy plus anti-PD-L1 inhibitor in 81% of patients. So after a median follow-up of 12 months, the ORR was 37%, and the disease control rate was greater than 80%, which is actually quite remarkable in the advanced refractory disease settings. Moreover, 43% of patients achieved stable disease. Duration of response is very impressive in this phase 2 study, with patients achieving a median duration of response of 10 months. It ranged from 6.9 to 11.1 months. Responses to Sotorasib were observed in key patient subgroups, including the PDL level, all PD-L1 expression levels, and in patients with tumors harboring co-mutations such as STK11 and KEAP1, which are usually predictors of resistance to checkpoint inhibitors. So the drug overall was well tolerated. Most AEs with Sotorasib were of low grade and manageable, as with other kinase inhibitors. We have to pay close attention to the gastrointestinal cutaneous AEs. The most common grade 3 treatment-related AEs were ALT elevation, AST elevation, diarrhea, and then the ones that led to dose modification in 22% of patients and discontinuation in 7 were listed there. Now, there were no deaths in the study. So the confirmatory multi-center phase 3 CODEBREAK 200 study is comparing Sotorasib with docetaxel in patients with locally advanced KRAS G12C mutant non-small cell lung cancer as a second-line treatment. In that patient population, docetaxel has historically shown a response rate of, 9% and a PFS of 2.9%. Thus, given what we have learned from the CODEBREAK 100 study of Sotorasib, I would, expect to see a benefit for Sotorasib and hopefully subsequent integration of Sotorasib in the frontline setting, or at least second line setting based on this trial, frontline eventually. We know that Sotorasib is also being evaluated currently in combination with other agents, prominent among them being immunotherapy agents such as pembrolizumab, EGFR inhibitors, and SHP2 inhibitors. So one of those combinations may even provide more benefit, especially in patients with subsets with co-mutations in the P53 or STK11. So another option for patients with non-small cell and EGFR exon 20 insertions, which we know traditionally is resistant to first, second, and even third generation TKIs. So Mobocertinib is a potent first-in-class TKI targeting EGFR exon 20 insertion mutations. Mobocertinib was initially evaluated in a phase 1 study with a dose expansion phase 2 with several different cohorts in non-small cell lung cancer, including with EGFR exon 20 insertion. So in World Lung 2020, Zhao and colleagues presented the data from phase 1/2 study of Mobo, and then the results from the EXCLAIM extension cohort that included results for patients who had received previous platinum-based chemotherapy from the dose escalation expansion cohorts. The primary endpoint was objective response rate by RECIST criteria. Secondary endpoints included safety, tolerability, pharmacokinetics, and efficacy. So the baseline characteristics in the two cohorts were relatively well balanced. The median age of patients enrolled in the study was 60 and 59 years of age in the cohorts. And then the 90% of patients in the EXCLAIM cohort and 100% in the PPP cohort, by definition, had received platinum-based chemotherapy. And at least a quarter of patients in each cohort received TKI or immunotherapy. Now, in the 96 patients from the EXCLAIM extension cohort, the response rate by independent review committee was 25%, which was similar to what was previously reported, and the investigator response was 32%. The median PFS was 7.3 months, and the duration of response had not been reached. In the PPP group, again, the independent review ORR was 28%. Investigator ORR was 35%, the median PFS 7.3 months, and then again, the duration of response had not been reached. In 78% of patients in the PPP cohort and 84% EXCLAIM cohort who had a response that lasted more than 6 months. So again, patients who don't achieve a response are presenting with stable disease. So what's exciting about this is more than 82% of patients in the PPP cohort and 80% in the EXCLAIM cohort had reductions in target lesion volumes. So when we talk about the progression-free survival, the median PFS in the PPP cohort was 7.3 months, and the duration of response, which is really important from the durability, was 17.5 months, which compares favorably with the historical PFS expected for this heavily pretreated population. In the EXCLAIM cohort, the median PFS and duration of response were similar, 7.3 months, and not reached. For me, really the key differences, and we're going to compare Mobocertinib with Amivantamb for time to come, the safety profile of these two EGFR 20 agents are slightly different. So you'll see that the safety profile, the grade 3 treatment-related AEs were observed with Mobocertinib in 40% of the patients. In the PPP cohort, the treatment-related AEs leading to dose reductions, treatment discontinuations were about 25 and 17%, and 1% of patients had death related to the drug itself. EXCLAIM cohort, similar numbers, 21% dose reductions, 10% discontinuations, and 1% death. The most common AE leading to drug discontinuation in both the cohorts were nausea, 4 and 2%, and then diarrhea, 4 and 2%. Of note, investigators also reported one treatment-related death due to cardiac failure, potentially related to the kinase inhibition of the mechanism of action of Mobocertinib. Now, so this is something we need to explore further in future studies. Of course, in this case, it's a small number. So to be continued. Moving on to Chrysalis, the other drug. Antibody, so it's a little different mechanism of action, but again, targeting EGFR 20 insertion mutations, which are traditionally insensitive to the classic inhibitors. So this Amivantamb is an EGFR MET bispecific antibody, and so the Chrysalis study was a phase 1 dose escalation expansion study, and it had patients who had previously progressed on platinum-based chemotherapy. And then again, they had the dose escalation and expansion cohort focusing specifically on non-small cell lung cancer, exon 20 insertions. The safety population was 114 patients, the efficacy population of 81 patients The primary endpoint, objective response rate, secondary endpoint included clinical benefit rate, duration of response, PFS, and OS. So in this safety population, the median age was 62, 22% had previous history of brain mets. Median previous lines of therapy was 2, range 1 to 7. All patients had previous platinum doublet. 46% had received previous immuno-oncology treatment, and 25% had received a TKI. First generation 9%, second generation 7%, and third generation 7%, or the multi-kinase inhibitor Mobocertinib in 1% of patients. Now, safety-wise, Amivantamb was relatively well tolerated. Greater than grade 3 treatment-related AEs were reported in 16% of patients. 21% at dose interruptions, 13% at dose reductions, 4% at discontinuation. But of note, there were no treatment-related deaths in this study. Now, so the safety profile of Amivantamb is consistent with EGFR and MET pathway inhibition. Most of the treatment-related AEs reported were mostly cutaneous and GI in nature. EGFR inhibition-related all grades AEs of rash, paronychia, stomatitis, pruritus were 86%, 42%, 18%, and 17%, as you can see. Only 2% of patients discontinued Amivantamab treatments due to rash. Now, the MET inhibition-related AEs of hypoalbuminemia and peripheral edema were reported in 15% and 10% of patients, respectively. Now, infusion reactions were reported in 66% of patients. Remember, Amivantamab is an intravenous drug compared to the oral TKIs we're used to. So the infusion reactions occurred during the first infusion, 94%, but this didn't affect their ability to get subsequent treatments with adequate pre-medications. So the objective response rate was 40% in the Chrysalis study and complete response in 4% of patients. The clinical benefit rate, which includes stable disease, was 74%, which is quite high for this patient population with refractory disease in which the available treatment are very limited with limited efficacy. So, and this objective response benefit was observed across all key subgroups of patients, included in patients with more than 3 lines of therapy, which is more than half the patients, and the median duration of response in this cohort was 11 months. So now moving on to IMPOWER 010 is the first study to show benefit for adjuvant checkpoint inhibition in non-small cell lung cancer. As you can see, they had patients greater than stage 1B with tumors greater than 4 centimeters with good ECOG. They were obviously post-surgery, as is the definition of adjuvant treatment, and they had to have tumor tissue, which they would because they had surgery. And they were randomized after their adjuvant chemotherapy of platinum-based doublet, 1:1 to Atezolizumab or best supportive care. The Atezo was 16 cycles. And then the primary endpoints were investigator-assessed disease-free survival in the PD-L positive group in the stage 2 to 3A population, all randomized stage 2 to 3A population, and the intent to treat 1B to 3A population. Secondary endpoints, overall survival in the intent to treat population, disease-free survival in the high PD-L expression, and then 3 and 5 year disease-free survival in all 3 populations. And they stratified patients based on gender, stage, histology, and then the PD-L1 tumor expression status. So as you can see, the disease-free survival in the PD-L positive group, any 1% or greater in the stage 2 to 3A population, which was the primary endpoint, you can see there's a clear difference here. The median disease-free survival is not yet been reached in Atezo group with best supportive care was 35 months. You can see really there is the curve separate very early at 3 months. The p-value here is significant. The hazard ratio is 0.66, denoting a 34% improvement in disease-free survival with Atezo compared to best supportive care. Now, if you look at the key subgroups, we want to see if there's any specific subgroup that does not benefit from Atezolizumab. You can see the age does not seem to matter, gender didn't matter, race didn't matter, ECOG score didn't matter. The current smokers seem to fare better with best supportive care, but look at the numbers, they're relatively small, so that's certainly something we'll have to keep in mind. It's not clear why that is. Histology didn't seem to matter. Now, when you look at the staging, stage 2A, 2B, 3A all seem to benefit equally. Node positive and node negative patients, though node negative patients are sort of approaching the midline, still seem to remain on the left side of the curve. The EGFR mutation status, we know that that's important in the adjuvant setting, as we'll talk about ADURA later. Didn't seem to alter the effectiveness of adjuvant Atezo, which is curious. And then ALK mutation, again, these numbers are small. Now, mutation status seem to be a little bit different, and that's something we'll have to keep an eye on. When you look at the disease-free survival in all randomized stage, which was the primary endpoint, also a significant hazard ratio of 0.79, p-value of 0.02. The median DFS, disease-free survival, was 42 months with Atezo, 35 with best supportive care. Now we look at the key subgroups and as spread out by the PDL score. Here you can see that the high PDL expression seem to do the best. They're furthest to the left. And then, of course, PDL positive and the PDL negative group is sort of riding in the middle. So we'll have to always wonder whether the PDL negative patients will benefit from Atezo that has a ratio. Again, it wasn't powered for that specific subgroup, but it does not seem to be significant in terms of benefit so far. So the disease-free survival in the intent to treat population, now this is 1B to 3A, which was the primary endpoint, managed to also be statistically significantly better in favor of Atezolizumab over best supportive care. Now, early overall survival data, the interim DFS analysis, again, it's immature at this pre-planned DFS interim analysis. It's not formally tested, but there's a trend towards overall survival improvement with Atezo in the PDL positive stage 2 to 3A population. So the conclusions, this is the first phase 3 trial of adjuvant immunotherapy to report results. Atezo improves DFS in hierarchical analysis for PDL positive resected stage 2 to 3A non-small cell lung cancer patients and all stage 2 to 3A as well. The OS data is immature. AEs are mostly immune mediated. I didn't go into the AEs, they're as expected. So this isn't FDA approved. We're watching to see how that plays out. Now, a 5-year update on the Pacific trial. Remember, that was a phase 3 randomized double-blind placebo-controlled trial with unresectable stage 3 non-small cell lung cancer patients who underwent chemo-RADs, followed by Durva versus placebo for 12 months. Primary endpoints were progression-free survival, overall survival. Secondary endpoints were response, duration of response, safety, and patient-reported outcomes. So at 5-year follow-up, it's really exciting to give some overall survival update data. Hazard ratio is 0.72. So clearly Durva has held up at the 5-year follow-up. The median overall survival is 47.5 months in the Durva group compared to 29 months in the placebo group. And so this is really exciting, and it just reassures us in terms of what we're doing. Being the right thing. PFS also significantly improved, 16.9 months with Durva compared to 5.6 months with placebo. So we know that this is robust and sustained PFS and OS benefit seen in patients receiving Durva for 5 years, and unprecedented survival seen at 5 years. More than 40% advanced stage lung cancer patients remaining alive, a third without disease. Again, there are still questions. Do all patients benefit with Durva? You have the EGFR mutant subsets would be referred to before based on IMPOWER 010 data set, and then the PDL negative patients, which tend to not respond so well. So there's still questions on what we can do with those patients. Now, moving on to ADURA, we know that 30% of patients who are resectable sometimes have a driver mutations. We don't traditionally test these patients. Though adjuvant chemotherapy improves OS and DFS, and now we have adjuvant, maybe checkpoint inhibitors, recurrence rates still are high, about 30 to 70%. So Osimertinib, as you know, the 3rd generation TKI, it's approved in EGFR mutated metastatic non-small cell lung cancer in first-line setting, and for T790M mutations in those who have progressed after 1st or 2nd generation TKI. So the ADURA trial is adjuvant Osimertinib versus placebo after complete tumor resection, plus or minus adjuvant chemo in patients with stage 1B through 3A EGFR mutated non-small cell lung cancer. So this was an international double-blind phase 3 trial. And so this is interim analysis of patients who had been resected with EGFR exon 19 deletion or L858R mutation who were stratified by stage, but were randomized to OC versus placebo for 3 years. The primary endpoint was investigator-assessed disease-free survival in patients stage 2 to 3A disease, and then secondary endpoints with disease-free survival in the overall population. And then, of course, landmark DFS rates at 2, 3, 4, and 5 overall survival, and really patient-reported quality of life and safety. So the baseline characteristics are here, balanced in both groups. There were about 32% of smokers in both population. Reminds us that even the smokers could have driver mutations, 64% Asian. Remember, this was an international trial, 30% of patients stage 1B, 30%-ish stage 2, and sort of 34% stage 3A. So a third, and then all of them had EGFR 19 or L858R mutations, pretty much split half and half, mostly adenocarcinomas. More than half the patients had adjuvant chemotherapy. So when you look at the disease-free survival in these patients, which is the primary endpoint, you can see, I mean, this is, you can drive a truck to this, the Kaplan-Meier curve, right? This hazard ratio is 0.17. It's unprecedented. The maturity is only 33%, but really, it's just irrefutable, the benefit of osimertinib for disease-free survival. For placebo, it's 20 months. For osimertinib, the median has obviously not even been reached. And the fact that it significantly prolongs DFS versus placebo is unquestionable. When you look at the DFS in overall population in stage 1B through 3A group, again, the hazard ratio is 0.21. It is still remarkably impressive when you look at the disease-free survival by subgroup in overall population. You can see the 1B group sort of approaching the midline, but still to the left of favoring osimertinib. Age, smoking status, the type of EGFR mutation didn't seem to matter dramatically, and whether they had adjuvant chemo or not also didn't affect their benefit from osimertinib. So when you look at everyone wants to tease out the stage 1B to see if they really are benefiting, because that's a tough one to sort of subject to 3 years of adjuvant therapy. And as you can see, the hazard ratio for even stage 1B was 0.5 and statistically significant. For stage 2 and 3, it was 0.17 and 0.12. So that just blew it out of the park for those advanced stage patients. Now, early OS data is trickling in. We have a long way to go. Maturity is only 5%, hazard ratio is 0.4. The curves are separating, and again, we need to see more of that improvement, given that when these patients relapse, we had OC as frontline treatment. What do we do with patients who have had adjuvant OC and they relapse, right? So those questions have not been answered yet. Safety-wise, no surprises. We know about OC, what kind of AEs it causes. There was a death in the placebo arm due to grade 5 PE. Grade 1 to ILD occurred in 3% of patients receiving osimertinib. Grade 1 to 3 QTC prolongation occurred in 7% of patients with OC and 1% of patients in placebo. That's something to absolutely keep in mind. All causality AEs, as you can see, diarrhea, paronychia is something we expect. All of these are all grades. Grade 3 and 4 is the dark gray, and 2% diarrhea, grade 3, 4, 1% paronychia, grade 3, 4, 2% stomatitis. So with osimertinib, that's something to keep in mind. But otherwise, all low grades AEs. So the conclusions at the unplanned interim analysis is that adjuvant osimertinib significantly prolonged DFS versus placebo after complete resection in early stage 1B through 3A EGFR positive non-small cell lung cancer, 83% risk reduction in recurrence of death or death, and then disease-free survival prolonged with OC across subgroups, including those who received prior adjuvant chemo, no new safety signals. And of course, investigators concluded that adjuvant OC should be incorporated into standard practice, and this was FDA approved for this indication. So we'll move on to DESTINY-Lung01. This is exciting. So I'll just go over the Cohort One results. The novel antibody drug conjugate Trasuzumab, Deruxtecan, and HER2 overexpressing metastatic non-small cell lung cancer. As you can see, DESTINY-Lung01 had many cohorts. The interim analysis of Cohort One is what we're going to present, with 11 patients who are still on treatment, 38 patients have discontinued. So really quickly, the characteristics of patients, 20% of patients had HER2 expression 3+, 80% at 2+. And then other characteristic abnormalities, as you can see, about 6% of patients had either EGFR, ALK, ROS1, or BRAF mutations, 34% had CNS metastases, and most patients had platinum-based chemotherapy and PD-1, anti-PD-L1 therapy in the past, and docetaxel, and median lines of therapy 1 to 8. With median being 3. So as you can see, in patients who had IHC 3+ or 2+ HER2 expression, the overall response was, as you could see, total 22% of patients had objective response, and 44% stable disease, 22% progressive disease. So 34% disease control rate, interestingly driven mostly by the IHC 2+ population, although the IHC 3+ population was a small number. The duration of response was 6 months. So this is interesting, and AEs are as expected, drug-related, decreased neutrophil count because it's an antibody-drug conjugate. As you can see, there's also drug-related AEs that are associated with dose reduction in about 35% of patients and 53% of dose interruptions, and pneumonitis in 10% of patients. That's something we have to keep in mind. So I'm not going to belabor sort of the drug-related ILD events. This is an important potential AE, 16% at ILD, grade 1 and 2 mostly, but there were a significant number of patients who, 3 who passed away due to ILD. So this is an AE of special interest. So with that, I conclude. I hope this was helpful, and thank you so much for attending.